Journal Club, and I am very much happy that Dr. Richa has consented to give a talk on our in Journal Club, and she will be talking a very important topic when we do dating scan, and during that dating scan, sometimes on eyeballing we get some findings, and she will be reading one paper on that. And Ashita will be putting her talk on the latest updated ISUOG guideline on first trimester scan, which is a basic and what is advanced. So we start with, I request Dr. Richa to start with the lecture.
So thank you, first of all, Dr.D'Pankar Banerji, sir, for giving me the opportunity to be here with all of you all today to talk about something which is very important. It's an excellent paper that sir has shortlisted. और बहुत ज़रूरी है डेली प्रैक्टिस में, especially for practicing obstetricians, also for sonologists. So I'll just be discussing one paper. And as we all know that in this era where non-stop medical legal suing is happening and lot of methodologies are in place, and we have when we have a sonography machine by our side, we can predict the outcomes, we can detect so many things just by, as it is said, the eye sees what the brain knows. So the topic for today in Journal Club is an excellent paper titled as Adverse Pregnancy Outcome in Fetuses with Early Increased Nuchal Translucency. It's a prospective cohort study. Bet, Lugart et al. All have been part of it, and it was done in Netherlands. So we know that increased nuchal translucency thickness is a well-established marker for adverse pregnancy outcome, and it is associated with euploidies, structural anomalies, and a wide range of genetic disorders. Moreover, it's also associated with increased chances of pregnancy losses. They did a prospective cohort study and in fetuses before 11 weeks. But the current distribution model to determine and increase NT is correlated to CRL, which is crown lump length, which ranges from 11.2 to 13.6 weeks. And in terms of CRL, it is from 45 to 84 mm, we all know, together with first, fifth, 95th and 99th centiles. The 99th percentile cutoff value and significance of increase NT is uncertain, as very few publications on this topic is available. NIPT, which is non-invasive prenatal testing, can be performed reliably from 10-week onwards. So dating scans are performed more often at 9 to 10 weeks. Thus, an increased NT is a more common finding with limited possibilities to evaluate fetal anatomy at this gestational age. So when increased NT is observed before 11 weeks, the sonographers in the Netherlands are currently advised to repeat the ultrasound, and then they do an NT measurement in the correct time, the correct framework, which is being followed from 11.2 to 13.6 weeks. In case of NT normalization, women can opt out from first trimester screening and consisting of NIPT or FTAs, that is first trimester anomaly scan. When a persistently increased NT is observed, women are referred to a fetal medicine unit for detailed ultrasonography and are counseled on the diagnostic options. So in this study, we found that an adverse pregnancy outcome in 24% cases of patients with a normalized NT as compared with 78% in the group with persistently increased NT. However, since the results were possibly subject to selection bias, they decided to do a prospective cohort study. They evaluated the clinical relevance of early NT, that is before 11 weeks, and in terms of a composite adverse pregnancy outcome, they continued the study till the termination of pregnancies, and they found out that it had euploidies, genetic disorders, structural anomalies, and it also resulted inadvertently on pregnancy losses. So cohort study was done between May 21 to 22 September in pregnant women whose gestational age was 9.0 to 11.2 weeks in Amsterdam, Netherlands. In Netherlands, it's a routine to do NIPT as a screening test. So they were counseled on the prenatal screening in the first trimester. These consultations were primarily done at midwifery levels and for low-risk pregnancies, while high-risk pregnancies were handled by the obstetric departments of the hospital. Routine measurements of NT is not a standard practice during the dating scan conducted between 9 to 10 weeks. They just used to take the CRL initially dating scan. For this study, they started measuring the NTs even at 10 weeks. However, when occasionally increased NT is observed visually and subsequently measured. Consequently, the midwifery practices and affiliated hospitals were asked to refer the patient to fetal medicine unit. Pregnant women were eligible even if they had a singleton pregnancy or twin pregnancy with viable fetuses or an isolated early increase NT. This was defined as NT 2.5 mm, that is 99th percentile for that particular gestation, and with the comparison, CRL ranged between 25 mm to 44.9 mm. They excluded pregnancies below with 16 years of age, maternal age, or maybe for patients who had insufficient knowledge of language, or they usually with a history with patients who had an increased risk of child with monogenetic disease or chromosomal anomaly based on the medical history. The cases with severe congenital anomalies were present at inclusion, such as body stock anomaly, were also excluded. This was this study was registered in the Dutch National Trial Registry. Eligible patients were informed, and after information, they were referred to fetal medicine unit. A subsequent NT measurement was performed minimum of 7 days up to maximum of 14 days after the inclusion ultrasound. And it always was between the 11 to 14 days, which we all know is the current guideline for doing an NT scan. A detailed first trimester anomaly scan was performed to determine the congenital anomaly following the ISUOG practice guidelines. Prior to this follow-up scan, the women were reminded of the details of the study and a written consent was obtained. They examined that the normalization of NT was found even in patients, in such patients who were called for the first trimester anomaly scan, and this was done under the guidelines of the Fetal Medicine Foundation. So therefore, an NT of less than 3.5 mm was scored as normalized, and NT of more 3.5 mm was scored as persistently increased NT. The follow-up data was collected 4 weeks after birth or at the termination of pregnancies. Also, in such patients where persistently increased NT was found, parents were also counseled about the invasive testing. We all know chorionic villus sampling or amniocentesis, and if everything worked up, it was performed. In such cases with a persistently increased NT of structural anomalies, parents were offered genetic testing in the form of invasive genetic testing, and an advanced ultrasound target scan or anomaly scan was performed at 20 weeks of gestation. Also, if they wanted, they could opt out of NIPT and sonographic follow-up, and they were informed about the limitations of NIPT. When after the follow-up data was collected, the children born in that particular unit, the electronic patient file was used. In elsewhere, the details were taken from midwifery and all the necessary data was collected. All participants received a short digital questionnaire 4 weeks after birth, and it was sent to them via email. So the validity of the study was more there, and the study procedure was outlined. They did according to the statistics, and the sample size calculation of the study focused on comparison of chromosomal anomalies between fetuses with persistently increased NT in the scan, that too with normalized NT. They had hypothesized that the incidence of chromosomal anomaly would be 27.4% or higher in the group of fetuses with persistently increased NT and 0.5% lower in the group with normalized NT. The main outcome was thought in the process of a composite adverse pregnancy outcome that consisted of either euploidies or genetic disorders or structural anomalies or ultimately pregnancy loss. This is any form, any gestation. They did a subgroup analysis on the basis of NT thickness at the inclusion ultrasound and normalized or persistently increased NT at the follow-up scan. They divided the genetic outcomes into two categories, euploidies and genetic disorders. Other genetic disorders were defined as chromosomal aberrations in the form of deletions, duplications, inversions or translocations, and monogenetic diseases. Pregnancy loss was determined as miscarriage or fetal death without a congenital anomaly. A normal outcome was a live birth with normal physical examination until 4 weeks of birth, which was determined with the help of a questionnaire. Now, during the study period, NIPT was performed in the context of a Dutch Trident study that primarily tests for trisomies of 21, 18 and 13, but also chromosomal aberrations on other autosomes. They could be tested if the parents desired. QF-PCR was also performed on such chromosomes, followed by microarray analysis if it was normal. Now, these were the ultrasound images. As you can see here, the NT was measured at almost before the 11 weeks at the dating scan, and it was collected. This is a beautiful image where you can see the enlarged NT and follow-up nuchal translucency scan according to FMF was done. I'd like to come to this important slide. The pregnancy outcome out of the total cohort, 74 children were live born. The mean gestational age at delivery was 39 points at 6 weeks. The mean birth weight was roughly around 3.3 kg and 50% for females. The termination of pregnancy was carried out in 24% cases. Miscarriages occurred in 6 cases and fetal death occurred in 5. The mean gestational age at termination of pregnancy was 14.5 weeks. In the 8 of these cases, the parents who opted for NIPT and mean gestational age was 15.4 weeks. In comparison to the 16 cases in which NIPT was not formed, it was around 14.2 weeks. Fetuses with an increased NT at the rating scan, maybe less than 11 week scan, are at a higher risk of adverse pregnancy outcome. That's what the study concluded. In the cohort of 109 fetuses of this study, they found out aneuploidies, genetic disorders and structural anomalies, almost say ranging from 20 to 4% respectively. Additionally, these 3 pregnancy losses occurred without any another diagnosis, and therefore the rate of composite adverse pregnancy outcome with a persistently increased NT was 35.8%. The rate of adverse outcome was significantly lower in fetus increased NT at the follow-up scan. In fetuses with the normalized NT and without ultrasound abnormalities at the follow-up scan, the incidence of adverse pregnancy outcome was 8.5%. I don't know whether this is visible or not, but because the limited retrospective studies on increased NT have shown that there is an association of an adverse outcome comparable to that of increased NT between 11 to 14 weeks of gestation. Additionally, many studies, they did the research and everybody reported that the fetuses with neck edema or generalized edema, CRL between 28 to 44 were followed up, and results also showed that NT normalizes after 11 weeks in majority of the cases. So the study concluded that fetuses with an increased NT before 11 weeks are at a high risk of adverse pregnancy outcome. Therefore, they advise that such fetuses with NT more than 2.5 mm, with that CRL measuring less than 45 at that gestation, that is when the CRL is less than 45 mm, they should be referred to a fetal medicine unit for detailed ultrasound scan and counseling about further diagnostic options in the form of routine NIPT or even invasive testing in the form of chorionic villus sampling or amniocentesis. A repeat NT measurement can be of a prognostic value, but the risk of adverse outcome is still increased if the NT is persistently increased. Therefore, the expected parents should be informed about their options and should not routinely be offered only solely the first trimester anomaly scan or NIPT. So this study that was done, and they had taken a lot of staff and of course fetal medicine unit into consideration, who facilitated and acknowledged the study. So I have spoken about brief about it. Also one slide that I'd all like to take through. This study had shown that fetuses with an increased NT area of had a considerable risk of an adverse pregnancy outcome, even if the fetal medicine unit found out that the NT normalizes after 11 weeks, and not all congenital anomalies can be diagnosed with routine first trimester anomaly screening, so and also such as NIPT and any detailed anomaly scan. Therefore, expected parents should always be referred to a specialist, and invasive prenatal testing should be offered. And if there is an increase NT of 2.5 mm, which is observed before 11 weeks of gestation. And thank you, Dr. Banerji, for making me read this. It did change my perception because I've been doing NT scans, but after reading this, probably I'll be paying more attention to the increased NT even at dating scan.
Thank you, Richa, for this beautiful talk. And it was a difficult paper, and it is a why this paper has come, because what is happening in world nowadays, few of the countries, they are doing Down syndrome or aneuploidy screening, primary screening through non-invasive prenatal test.
Yes.
Now, when you go for a non-invasive prenatal test for primary screening, not normally people are doing first trimester double marker.
Yes.
And first trimester anti-scan, which is called combined fetal screening.
Correct.
With age, with biochemistry, that is PAPE and free beta HCG, you get the biochemical risk. With that, you add during anti-scan the anatomy of the baby, the aneuploidy risk by different markers like nasal bone, nuchal thickness, lot of other things. So there is a combined risk calculated through this first trimester combined screening, which we are usually doing.
Yes, sir.
But the thing is, it requires a lot of calculation.
Correct.
So what is happening in world nowadays? What is the best sensitive and specific method to get the Down syndrome? They came that it is a non-invasive prenatal test. But the problem with the non-invasive prenatal test is, if a lady is having 2.5 months amenorrhea and you ask her to get blood test done, NIPT, and the baby is not alive,
then the values will
be useless and you are losing money and the government is losing money.
Yes.
So what they have started, you have to see whether baby is alive or not.
Yes.
Now you are doing an ultrasound.
Yes.
Moment you put an ultrasound, you are eyeballing the baby.
Yes.
Moment you see the whole baby there, aapka dimag, you go there and you catch that there is something behind the neck, there is a increased.
We do that.
But the anti-scan, which standardized by FMF and different European society and American college, is between 11 weeks to 13 plus weeks, 6 days.
Yes.
Now, what will happen if you see this thing in before, while you are confirming the baby is alive or not?
Yes.
The moment you see and do an NIPT, now the problem is You have taken this patient for NIPT.
Yes.
Now you find something abnormal on eyeballing. Now the problem is, if you go for primary screening for NIPT, the NIPT is not good for other. NIPT is not good for other genetic disorder. NIPT is not good for micro deletion and duplication.
Yes.
That means if you get this, then NIPT is not the answer.
Yes.
So what you will do, should go for fetal medicine unit, and fetal medicine unit, you have seen this in paper that either there is a normalization. Again, there is a problem with this word normalization, because they are taking this as a 3.5 millimeter as normalization less than 3.5.
Yes.
Now 3.5 is 99 percentile. If at a particular NT there is 3.5 mm, suppose it is 3.40 mm, then definitely risk of aneuploidy is very high.
High.
So the word normalization in this paper is little bit confusing. How can you say that it is normalized now? You should not do any invasive test.
According to the FMF guidelines, according to
So
CRL.
they conduct the risk.
Yes.
Now, moment you do the risk assessment with this 3.4, 3.3, most of the time it will come below 1 out of 250 or 1 out of 1000 or 1 out of 500.
Yes.
So either it will be in a high risk or it will be an intermediate risk.
Yes.
Moment it comes, what is your answer? Then it is invasive. That means what is happening in world now, this paper has come, when we do biochemistry, for biochemistry lab needs CRL. That means you do an ultrasound at 11 weeks. If you are not doing NT at that time, so you are doing an ultrasound for CRL.
Yes.
With that CRL, you are sending the patient's blood. Now, most of the time what you do an NT scan along with that and take blood, and there will be a combined
screening.
The thing is, this paper has been, there is another letter to the authors in this same journal. That means you are doing 2 scans.
Yes, a dating before that and a detailed first
so
trimester.
better you can do
Only
on one scan. So if you go for the resources, then there will be, if the patient is putting money from her pocket, then she has to give
2 times.
So this is a problem with those where the NIPT they are taking as a primary method.
But that's happening in Netherlands, not in India.
Not in India, but 4 countries they have opted this.
As NIPT as a primary
screening. Now the problem is, patient is coming at 2.5 months for the dating scan. Now dating scan you will say it is not in NIPT range, but you are seeing something different. That means you can decide at the time of CRL if you are doing biochemistry or you are doing NIPT, take a decision for those cases where the nuchal thickness you feel it is high, even though it is not in the NT range, that is in FMF guideline range. And if you don't do invasive test in this, there are cases, there are many, they did exome sequencing also, and there are Noonan syndrome like cases, and they have got that. Fortunately, with 3.5 normalization, less than 3.5, 4 cases did well. But if you don't do invasive test, it is a very risky affair to leave these babies. It is my view.
Because you've been doing probably, but how can you justify doing so many invasive testings?
No, invasive test is required when it is required. If you eyeballing a case at 10 weeks, and if you see there is a high amount of nuchal thickness, which is not in 11 to 14 weeks range, then what you will do? You will call them again at the time of 11 to 14 weeks.
I will.
If it is still high, then you have to do a invasive test.
Yes.
But it was high, now it is normalizing. There are many cases in their paper, they are having abnormal outcome.
Yes.
So this abnormal outcome would have not been identified if they would not have done the invasive test.
Yes.
So my statement is that sometimes it becomes too much costly if you do 2 scans.
Yeah.
So you have to make a guideline for the 9 to 11 weeks also.
They should.
I think they will come with that.
Yes.
And it will come more because the machines are becoming better and better.
Better and better.
So this is very thought-provoking paper. That's why I give it
Yes,
to you.
absolutely.
And I think it will change your practice
My
also.
practice also.
Thank you very much.
So thank you so much. Thank you for having
Yeah,
me.
Ashita. Now, Ashita will be talking on Ashita will be talking on the latest updated guidelines for 11 to 14 weeks, the salient features which we should see when doing this first trimester scan with ISUOG guideline, so that there are 4 things which we should go for assessment of the fetus during anti-scan. First is anatomy, second is a risk calculation for aneuploidy, third is whether IT is there or not, so there is open neural tube defect or not, and fourth is assessment of pre-eclampsia in later part of the pregnancy. So I request Ashita to start with her topic on ISUOG guideline, which is a updated guideline which includes nowadays with you have to measure bilateral uterine artery PI, mother's body mass index, her height and her weight, FHR, and we should able to see the IT also. And with this, I think she is prepared now, and go ahead with this.
So, good evening, everybody. So, I'll be starting with the ISUOG practice guidelines. Earlier also, they had released a guideline for 11 to 14 weeks, and recently in 2020, they have updated it. So, introductions of performing a routine scan at 11 to 14 weeks is of value for confirming many factors. First of all, we see the viability. The first thing when we put the probe, first we look for is cardiac activity, whether the fetus is viable or not. Then we see whether how many fetuses are there, whether it is a multiple pregnancy, it is a single pregnancy. Then for accurate pregnancy dating, then screening for aneuploidies, identification of any major structural anomalies, because almost 50 to 60% of anomalies can be identified at this stage, and also screening for preterm preeclampsia. Then when should a first trimester scan be performed? So ideally we perform it between 11 to 14 weeks of gestation, and before starting the examination, important thing is to counsel the couple or the woman regarding the potential benefits and also the limitations of the first trimester scan. Performing a first trimester anomaly scan does not mean you can skip a target scan at the second trimester, or you can skip future scans. So all anomalies cannot be seen at this stage, but a lot of anomalies can be seen, and a lot of screening process and diagnosis can be made at this point of time. Now, who should perform a first trimester scan? So they have provided a specific guidelines like who can perform this scan. So people who have completed training in the use of diagnostic ultrasound and related safety issues, participating in continuing medical education activities, following established care pathways for suspicious or abnormal findings, and participate regularly in established quality assured programs. Now, is prenatal ultrasound safe during the first trimester? So a lot of couples have this question whether it is safe to perform a scan, because it takes some amount of time. So whether it is safe to perform such a scan for a longer duration at this time. So for this, ISUOG has an ALARA principle, as low as reasonably achievable. That means जितनी जल्दी हो सके और जितना मैक्सिमम बेटर आउटपुट आपको मिल सके उसमें इस स्कैन को परफॉर्म करना है. Doppler ultrasound is usually avoided before 11 weeks because that is the period of embryogenesis. So we should avoid performing a Doppler ultrasound because it is a high energy process and it may have some negative impacts on the fetus. Then when performing the ultrasound, the thermal index and the exposure time should be seen. Thermal index, it is usually displayed in the machine, it should be less than 1, and the time should no longer be 5 to 10 minutes. So many a times what we do that if it is taking longer, many a times the baby is not in the correct position for NT to be measured, for CRL to be taken. So we can stop the scan at that point of time, review after half an hour, review after 1 hour. So continuous exposure to ultrasound for longer duration does more harm because continuous exposure causes production of heat, and that is what we are scared of at this point of time. So whenever we need longer time, we need to continue the scan for a longer duration, we can stop it at that point of time, send the patient, call her back after half an hour, after 1 hour. Then what should be done in case of multiple pregnancies? So for multiple pregnancies, what is important? At this point of time, we determine the chorionicity, the amnionicity, and this is the ideal time for for determining the chorionicity and amnionicity, because as the pregnancy will progress, this will become more and more difficult. And as we know that monochorionic pregnancies are associated with more complications, need more monitoring and follow-up. So if we label them as early as possible, then it helps us in future planning of treatment and follow-up visits. Now, guidelines for examination. So first thing, assessment of viability. For viability, the heart rate is recorded and is usually measured either using the M mode or spectral Doppler, and can be assessed over a number of cycles. Heart rate, what ISUOG has suggested that usually it increases with gestational age up to 10 weeks and it is mean around 171 beats per minute, and then decreases till 14 weeks around 156 per minute. So for every gestation age they have a different mean, that at this gestation age this is what should be considered normal, and at 14 weeks around 156 is considered normal. So if there is fetal tachycardia or bradycardia, that means if it is too high or too low compared to the normal, then sometimes it is indicated of an aneuploidy or associated cardiac abnormality. Then confirmation of intrauterine pregnancy or uterine integrity. So an intrauterine sac should be bounded completely by the myometrium, and it is best assessed by performing a sweep covering the entire uterus. So whenever we are doing a scan, usually we do a transvaginal ultrasound at this stage also. So we can perform a complete sweep and see that the sac is completely bounded by the myometrium. This point is mentioned over here because many a times there is a cesarean scar pregnancy, which is a very rare phenomenon. So in that case, the myometrium does not cover the whole of the sac. So to rule out that, this point has been suggested because due to the increasing number of cesarean sections, cesarean scar pregnancies are also becoming common. And also many a times an ectopic pregnancy, which is also there along with the intrauterine pregnancy, can be missed. So whenever we are doing a scan, we should perform a full sweep first. Then fetal biometry. There are specific charts which are available for assessing the first trimester fetal biometry. The CRL, which is should be used as a gestational reference to define whether measurements of NT, uterine artery PI and biochemical markers, that is pre-beta HCG and PA-PPA and PIGF, in relation to the normal range. So the most important thing to measure at this point of time is CRL. CRL means gestational age. That is what we have learned throughout. So the actual gestational age, which is taken from the last menstrual period, is not taken into consideration when we are looking for these biochemical parameters. So every time we have to take the CRL, according to that the gestational age, and according to that we will take the reference values for these biochemical parameters. Now BPD measurements adjusted for CRL and or abdominal circumference or transverse abdominal diameter can be used in early screening for meningomyelocele and holocrosencephaly. So this is an important point over here. Whenever we are measuring BPD, or whenever we are measuring abdominal circumference. So not only that, we can also see a gross structural anomaly at that point. If the shape of the skull is very irregular, if the shape is not normal, if there is some protruding mass coming out of it. So at this point of time, we can see that. So whenever we are doing the biometry at this point of time, we can also look for other obvious abnormalities which can be seen over here. Abdominal circumference not only is used for biometry, but we can also the stomach, umbilical vein at this plane. Then femur length. Then advantage of performing a femur length is that we can see that the lower limbs are appropriate for gestational age or not, because whenever there are skeletal abnormalities, skeletal dysplasias and defects, many can be presented as this early stage. So a very discrepancy in the abdominal circumference and the head circumference is in correlation with the expected gestational age or CRL, and we find a very small femur length, so it can raise a suspicion that there might be some problem. So this is the table that they have provided for reporting, that we have to report these 5 parameters at least. Now for the anatomy scan. So for anatomy scan, they have 2 different guidelines. One is the basic and one is the advanced guideline. So for the basic guideline, they have reported that if you are not comfortable with performing a very detailed scan, a very detailed anatomy scan, and so you can perform some basic things, very basic things which you have to see in a first trimester scan. So these include head and brain. We see the shape, ossification, whether fox is present or not, and the butterfly shaped choroid plexus, which can easily be seen. If you are measuring the BPD correctly, if you are taking the head circumference, you can see all these factors. Then in the heart, we see whether it is there in intrathoracic position and it is regularly beating. For abdomen, when we are taking the abdominal circumference, we see the stomach is present, abdominal wall is intact or not, and bladder, whether it is dilated or not. We can see the upper extremities. We have to see the 3 segments. That means this forearm, arm and hand. These 3 segments have to be seen. And whether the placenta is normal without any cystic structures. So this is the very basic parameters which they have given, which have to be mentioned in the report. So what does this mean? This means normal, abnormal and not visualized. So if it is normal, you can report it to be normal. If you find any abnormality, it has to be reported. And if you're not able to correctly determine any of these factors, it has to be reported under not visualized, and you can call the patient for a review scan after a few weeks. Or you can refer the patient to some other sonologist for a second opinion. Now for performing the detailed anomaly scan. So for the first trimester, for detailed anomaly scan, in the head, we have to see for intact cranium, the shape, midline fox, choroid plexus, lateral ventricles also. Earlier, lateral ventricles were not included. In the updated, they have included the lateral ventricles, IT, brainstem, cisterna magna. All these were not included in the previous 11 to 14 week scan, but they have updated it now. And cerebral peduncles with AOS. Now, face and neck. Nuchal translucency, this was present, but the retronasal triangle maxilla mandible, these 2 are added. The NT was earlier given in the measurement box when the BPD and everything, NT was mentioned over there, but they have added it over here. Now, retronasal triangle and maxilla and mandible also have to be seen. So earlier they only considered a midline view. That was all mentioned, whether you can see whether you're seeing that or not, but now they have these specific things and orbits. In thorax, the shape with lung fields and diaphragmatic continuity. It is the same like previous guideline. In heart, intrathoracic with regular rhythm, cardiac size axis, 4-chamber view. These 3 things were previously mentioned, but they have added left ventricle outflow, right ventricle outflow and 3-vessel trachea view. These 3 things have been added. So many a times it becomes difficult at this stage to look for the left ventricle, and this is actually part of the detailed cardiac screening which we do. So many a times it is difficult. So if it is not visible, we can always say it is not visible and call the patient again rather than labeling it as normal if we have not seen it. Then in the abdomen, stomach filled, then bladder, and they have specified it should be less than 7 millimeters. So at this stage, if bladder is more than 7 millimeters, that means there might be some obstruction below the level of the bladder, which has to be taken into consideration. Intact abdominal wall and 2 umbilical arteries have to be seen, and kidneys. It is similar to the previous guidelines. Spine and upper and lower limb with 3 segments is similar. Now this was part of the anatomy scan. So every time when we look for a first trimester scan, it has 3 parts. One is anatomy, which we have already seen. Second part is screening for aneuploidy. Aneuploidy means problem in the number of chromosomes. So for problem in the number of chromosomes, and the third part is screening for pre-eclampsia. So for assessing trisomies, so most common is 21, 18 and 13. First thing which is important is pre-test counseling. Then there are 2 tests which are generally used. One is a combined screening and the other one is NIPS. So the patient can choose from either of these, and you can decide on the basis of the findings of your scan as well. And apart from this, other important things which have to be seen for assessing aneuploidy is nuchal translucency, which we had already discussed. It has specific values for gestation age, and high NT is associated with aneuploidies and other structural anomalies as well. Similarly, nasal bone. Nasal bone is another marker which has to be seen at this stage. Absence of nasal bone or hypoplastic nasal bone is associated with aneuploidies. So these patients have to be reassessed. Ductus venosus or DV. So absent of A wave in the ductus venosus Doppler actually gives us an idea. It is a high risk for trisomy 21. And similarly, tricuspid regurgitation. Presence of tricuspid regurgitation is also a high risk for aneuploidy. Another thing which I forgot to mention is presence of IT, which they have mentioned. IT is internal translucency. So presence of IT actually gives us a lot of idea. It rules out in a way that if the IT is not visible, that means there might be a neural tube defect in the baby. So presence of IT somehow rules it out. And post-test counseling is very important, that since we have performed everything and everything is normal, still we have to continue our monitoring and follow up for a detailed anatomy scan in the second trimester. And screening for pre-eclampsia. So for pre-eclampsia screening, they have recommended measurement of uterine artery PI, serum PIGF and mean arterial pressure. Serum PIGF is optional. If it is available at the center, then it can be measured. And more than 1 in 100 is taken as a cutoff over here to screen test positivity. So for risk assessment, NT, NB, DV, A wave, tricuspid valve regurgitation, is yes or no, then right artery PI and left artery PI. So this is the table they have given, which you have to report in it. Thank you.
Thank you, Ashita, for this important thing which is described in ISUOG guideline, which is at present in 23 they come with this detailed 2 type of first trimester scan. Basically, why I keep all these things always again and again with ISUOG guideline is that whosoever is doing ultrasound, if you follow this ISUOG guideline, then there are very, very less chances of omitting or missing a anatomy. It might be difficult for us to assess the aneuploidy, which is done by lab or what we do bedside also. And one thing is very important, that if you are not able to see, then better write it is not visualized. Because what is happening, what has been included in the latest guideline with advanced one, if you do a transvaginal ultrasound while doing nuchal translucent or this first trimester screening, I think what I do is better to start with the transvaginal scan, which gives a very, very good idea about the anatomy they have mentioned. It gives a very good idea about the four-chamber view. It gives a very good idea about LVOT and RVOT. Sometimes might be difficult to get the three-vessel trachea view. But if you can get it, then basically you are doing a very good target scan at the time of 11 to 14 weeks scan. And with that, if you can able to do the different markers of aneuploidy like nuchal thickness, translucency thickness, this ductus venosus A wave, and tricuspid regurgitation and presence of nasal bone. So these things gives you an idea of aneuploidy is common or not, even though it is very, very important to understand that we should never give our report as complete.
Yes.
They have included a conclusion that it is normal and complete, normal and incomplete, and abnormal. If it is abnormal, then you write abnormal. But we should always write it is normal but incomplete. Why? Because many things which may appear later on in pregnancy which might not be seen in first trimester scan. So you might be asked that why you have missed it, because it is not possible to do. So these things are very important, and it is very, very important to understand that even though if we give a normal but incomplete scan report with low aneuploidy screening, it is always there are chances that there might be Down syndrome. So ultimate is invasive method. But definitely if you have a good scan with anatomy with aneuploidy screening, chances of missing aneuploidy is very, very low. So better, all tests of invasive test cannot be applied to all, but all patients, what American College of Obstetrics and Gynecology recommended, even ISUOG recommended, that there should be a sentence that if you have anxiety, you can go for invasive also. But with your ultrasound, with your pre-test counseling, with your work and post-test counseling, patient might get a very good relief with your good ultrasound. These are the messages what Richa has told that, Richa, either. What Richa has told about this paper, one paper is pre-11 to 14 weeks scan. I think this makes a little bit, this widens our approach towards seeing the baby.
Absolutely.
And the whole world is reaching as early as possible to identify the abnormalities in the baby so that the couple can take a decision. And one thing is very important, whosoever is doing fetal scan, always think about that the mother is looking at you and always asking you whether my baby is okay or not. And if you have any doubt, if you have any, it is better to take a different second opinion from your more experienced person and tell the correct truth about that. These might be a possibility. It is not that you overdo for making them more scared, but definitely when we see these type of things, we should have in mind that there should be a healthy outcome. And one thing is very important, if you miss it and something happens, then you are liable to give answer also.
Yes.
So these are very tricky things, and doing fetal medicine is not an easy task. To counsel a pregnant lady is not an easy task. It is a very important and very responsible job for anybody who is doing. Thank you very much for both of you for making this journal club successful. Thank you very much.
Thank you.